Surgery of Ear by Glasscock and Schamberg, Chapter 28. Tympanoplasty, Tympanic membrane repair. Cartilage tympanoplasty techniques. Although temporalis fascia and perichondrium still remain the most commonly used graft in tympanoplasty and the reported results are excellent, they both have potential to atrophy, resulting in failure, especially in such high risk ears as those with atelectasis, cholesteatomas, and prior surgeries. Since UTEC in 1959 and the Heeman and Jensen in the early 1960s reported their experience with cartilage grafts in tympanoplasty, many authors have described their use either as a palisade, perichondrium or cartilage island flap, or cartilage shield for cases at high risk for failure. Conchal and tragal cartilage are two most commonly used cartilaginous grafts and they resist resorption and retraction even in the face of estrogen tube dysfunction. Another advantage of the grafts is the feasibility of ossicular reconstruction at the time of grafting. Perichondrium or cartilage island flap and palisade technique. The perichondrium or cartilage island flap and palisade technique have been popularized in the United States by Donhofer, and the tragus or concha are the donor sites used in these techniques. In the perichondrium or cartilage island flap technique, a piece of tragal cartilage measuring 15 mm in length and 10 mm in width is harvested. One side of the perichondrium is elevated, leaving the reverse side attached. Using a knife, cartilage is removed to create an eccentrically located disc of cartilage measuring approximately 7 to 9 mm in diameter. Then a 2 mm strip of cartilage is removed vertically from the center of the cartilage to accommodate the manubrium. In cases with an intact ossicular chain, an additional triangular piece of cartilage is removed from the posterior superior quadrant of to accommodate the incus. The middle ear is packed with gel form anteriorly at the estrogen tube, but the promontory and ossicular chain are left devoid of any packing. The graft is placed in an underlay fashion with the cartilage facing the promontory and the free perichondrium extending posteriorly, draping over the bony canal wall. In palisade technique, the cartilage is sectioned into several sizes which are pieced together to reconstruct the tympanic membrane. The more curved Simba concha is considered a more suitable donor site, although tragal cartilage is also an option. This technique has been found useful in the reconstruction posterior tympanic membrane perforations with associated ossicular disease necessitating synchronous reconstruction with PORPs or TORPs. In cases with cholesteatoma, it can be used to reconstruct the scutum and posterior superior quadrant to prevent recurrence. Cartilage shield tympanoplasty. For the past 10 years, cartilage shield tympanoplasty (CST) has been the author's preferred technique for cases requiring total replacement of the tympanic membrane, cases with questionable or borderline estrogen tube dysfunction, atelectatic ears, cholesteatomas, tympanoplasty failures, laterally displaced tympanic membranes, and atresia cases. The technique used is a modification of the one described by Duckert et al. For primary and secondary acquired cholesteatomas. Posterior perforations, especially when titanium ossiculoplasty is performed. The author prefers the palisade technique as described previously. The CST, cartilage shield tympanoplasty, is considered by the author to be a less technically demanding and less time consuming procedure than the perichondrium or cartilage island flap technique. The CST, cartilage shield tympanoplasty technique, proceeds as follows. Under general anesthesia, vascular strip incision are made in the ear canal following by a postauricular incision. Areolar tissue overlying the temporalis fascia is harvested and the vascular strip is elevated out of the ear canal and kept in position using two self-retaining retractors. Access to the ear canal and the tympanic membrane is accomplished via the postauricular area. A canaloplasty is performed in cases with bulging of the bony anterior canal wall to improve visualization of the anterior sulcus. The edges of the perforation are denuded and areas of tympanosclerosis are completely removed. The middle ear is explored, the status of the ossicular chain is determined, and any pathology found is removed. At this point, a mastoidectomy is performed if deemed necessary. A round piece of cartilage, approximately the size of the tympanic membrane defect, 10 mm, is harvested from the concha simba area. The initial size of the cartilage graft should be slightly larger than the tympanic membrane defect and is gradually trimmed with a scissors to the proper size. The perichondrium is stripped from both sides and a wedge of cartilage is excised to accommodate the manubrium. The middle ear is packed with gel form and cartilaginous graft with its convex surface placed medially and is placed underneath the manubrium by lifting it up with a small right angled hook while gently pushing the graft medially with a 22 gauge suction. Subsequently, the periphery of the cartilage graft is placed medial to the tympanic membrane remnant or the fibrous annulus. If there is no fibrous annulus, the cartilage graft is placed at the level of tympanic sulcus. There is no need to create a groove in the anterior bony wall to accommodate the graft. A very small gap less than 1 millimeter is allowed between the graft and the tympanic sulcus. It must be emphasized that a tight fitting, oversized graft should be avoided because of reduction in eventual vibrational properties. For patients with medialization of the malleus, the tensor tympani tendon can be sectioned to lateralize the manubrium and allow medial placement of the graft. In case it is required, ossicular reconstruction is performed with a TORP or a PORP or a type 3 tympanoplasty. The previously harvested areolar tissue is placed over the cartilage graft and medial to the tympanic membrane remnant or fibrous annulus, so any small gaps are bridged. The vascular strip flap is returned to its original position and two Pope's ear wicks impregnated in antibiotic ointment are inserted in the ear canal to secure proper position of the vascular strip. The postauricular incision is closed in two layers with 30 vicryl sutures. A rubber band drain is left in the most dependent area of the incision and a mastoid dressing is applied. The concha simba cartilage is wide within the operating field, has an average thickness of 0.8 millimeter and its concave contour resembles the conical shape of the normal tympanic membrane. This cartilage has an average thickness similar to fossa triangularis cartilage 0.775 mm and is thinner than tragal cartilage 1.016 mm. In the technique described by Duckton et al., the perichondrium is left in place and the cartilage is thinned. The author, in order to achieve a thinner graft, strips the perichondrium from both sides of the cartilage graft. There has been neither graft lateralization nor collapse into the middle ear space in the author's experience, and therefore there is no need to create groove in the bony sulcus for graft stabilization as recommended by Moore. Despite the cartilage thickness, 78% of patients following CST have type A or type C tympanogram. If a middle ear effusion develops in the post-operative period, myringotomy with tubing can be performed. Although the thickness of the cartilage graft may decrease the middle ear space, this has not had any significance adverse effect on the hearing results. In the post-operative temporal bone CT scans, space can be detected between the cartilaginous graft and the promontory. In a considerable number of patients with no incus and a contracted middle ear space, the cartilage thickness makes a type 3 tympanoplasty feasible, obviating the need for PORP. Hearing results in such cases are similar to those obtained by PORP. A potential disadvantage of this technique is the cartilage opacity and possible concealment of the recurrent or residual cholesteatoma and middle ear effusion. These potential problems can be avoided by performing a second loop procedure in all cholesteatoma cases in 12 months following the initial surgery and a diagnostic myringotomy in case of suspected middle ear effusion. Regardless of the tympanoplasty approach or technique used, involvement of the mastoid antrum with cholesteatoma necessitates either a CWD or an ICW mastoidectomy. The ICW mastoidectomy can be used in the majority of cholesteatoma cases and is the preferred method over the CWD technique since it avoids the creation of an open mastoid cavity with the associated need for long term cleaning, restriction of water activities, and recurrent infections. This technique results in an ear that is anatomically and functionally closer to normal. However, this technique is associated with a higher incidence of residual or recurrent cholesteatoma. For this reason, a second stage procedure, usually 1 year later, is required. Residual cholesteatomas is defined as persistent cholesteatoma in the middle ear or mastoid cavity following incomplete removal. Recurrent cholesteatoma develops following complete removal due to retraction of the pars flaccida or the posterior superior quadrant of the tympanic membrane. Both mastoidectomy techniques, when properly performed, give very satisfying results.